All right. Well, welcome everybody to the UCSF Stanford CiRCE FDA Distinguished Speaker Series on Cybersecurity for Biomedical Engineering. We meet every third Thursday of each month during the academic year. And welcome to the second seminar of 2023. I'll just give a couple introductory remarks before we get into our speaker for today, Ken Hoyme. First, a disclaimer. This seminar series does not represent official FDA policy or guidance. The contents are those of the speakers and do not necessarily represent the official views of, nor an endorsement by, the Food and Drug Administration, HHS, or the US government. This seminar is being recorded. A little bit about myself. I am the moderator today, Kevin Fu. I'm a professor at Northeastern University in Boston in electrical and computer engineering and the Khoury College of Computer Sciences. I also previously served as the acting director of medical device cybersecurity at FDA. And if you'd like to connect with me, you can find me on most of the social medias there as Dr. Kevin Fu. A couple announcements from one of our co-sponsors, the FDA. The FDA is hiring. You may have heard from the Omnibus bill of a few months ago. If you're interested in a career in cybersecurity for medical devices at the FDA, contact Diane.Mitchell at fda.hhs.gov or find any of the many job postings on various recruiting websites. So why are we here today? Well, there have been a lot of interesting changes in the last year. Almost a year ago, the Wall Street Journal published an article from a ransomware hacking group where after a schism in the group, part of the members of the group outed the others, showing the chat transcripts that they were planning to attack more than 400 US hospitals. So the threats against medical devices and hospitals have gone from theoretical to nation state supported. And these are unfortunately endemic cybersecurity threats that medical devices need to be able to tolerate today. And then hot off the press, just a couple days ago in the Wall Street Journal, there was an article talking about the new federal law and authorities given to the Food and Drug Administration to regulate medical device cybersecurity. And you'll be hearing more about that today in our discussion with Ken. Of course, cybersecurity is key for all sorts of things in biomedical engineering. There are regulatory aspects, there are public policy aspects, and even in the United States, the president issued an executive order improving the nation's cybersecurity for its civilian networks. Now, in the last year, FDA has been quite busy. It published the draft pre-market guidance known as Cybersecurity in Medical Devices, now under the umbrella of quality system considerations and content of pre-market submissions. This is not yet final or for implementation, but the public comment period did end last July. In December of last year, the omnibus bill passed, and inside that omnibus bill were a few pages that were highly relevant to medical device cybersecurity. And you'll see that this law comes into effect in March, so in just a couple of weeks. And FDA has been quite public that it is studying this law and understanding how it's going to implement its new authorities to regulate medical device security, no longer just optional or recommended, but part of federal statute. So with this context, medical device security, new regulatory authorities, medical device security threats, moving from kids in the basement to nation state level hacking groups. How can we protect medical devices, ensure that patients still receive safe and effective diagnostics and therapies? Well, today, it's my pleasure to host Ken Hoyme. He is recently retired and he is now an advisory board member at MedCrypt. We're going to have our fireside chat on lessons learned after 2 decades of medical device security engineering. I want to tell you just a little bit about Ken's background. I think it's rather unique for all the professionals in the field of medical device security. So he's been working in this area of system design for over 40 years in highly regulated and safety critical systems, everything ranging from medical device design to aircraft flight control systems. So he recently retired from Boston Scientific as a senior product security fellow, where he established the company-wide product security program. He has also been extremely active in leading and co-leading various standards working groups on medical device security for the past decade. And previous to working in the medical device industry, he spent 18 years at Honeywell, where he was a senior fellow. And before that, he received his bachelor's and master's in electrical engineering from the University of Minnesota. So Ken, it gives me great pleasure to have you. I don't have a virtual fire at the moment today, but it gives me great pleasure to host you. I should say today you're welcome to, participants are welcome to add questions into the Q&A. Ken and I have quite a bit of dialogue to get through, and then we're going to go through the Q&A toward the end of the talk in the last 15 minutes or so. So please excuse us if we're not looking at the Q&A just at this very moment, but we'll be getting to those toward the end of the session. So Ken, welcome to the program.
Thanks, Kevin. Looking forward to the chat. It's been a long journey.
It has been a long time. And I was thinking maybe you could take us backwards in time a little bit. I know you and I first met around 2008.
Correct. There was this paper that came out in 2008, and I first learned about the paper in March when, after the schedule of accepted papers were published for IEEE security and privacy, there was this paper in there about hacking defibrillators. And a blogger blogged about it, and New York Times and Washington and the Wall Street Journal both were reaching out to cardiac companies to get comment. And the paper was released on embargo. I got it on email from our R&D vice president asking me to be in a conference room, his conference room, 15 minutes later to prepare comments with our corporate communication. So it was kind of one of these out of the blue, like, whoa. And so I and Grace Weekend, who I think is online here today, attended the conference in Berkeley where the presentation was made. And I think that was the first time we met as we were trying to understand who these characters were that were hacking into cardiac devices. So it was, yeah, I mean, that really started a period of researchers demonstrating feasible attacks on medical devices. So yours with your teams with the defibrillator was first. Later, we saw Jay Radcliffe and others focus on insulin pumps. And it really was a period where I think medical device manufacturers were kind of taken aback about, what was the motives of these people? Why were they doing this? Isn't this dangerous? And so I think we saw a period of antagonism between the researchers and the companies as we were trying to figure out what was going on. So,
yeah, and that's now about 15 years ago. So certainly times have changed. In the field, you have to be constantly looking at where the things are going. But I seem to recall back in 2008, there were no standards for medical device security. There were generic security standards, but nothing specific to medical devices.
Yeah, and I think before that, the FDA had their guidance on, updating software related to that, but it persisted. It probably even persists in the minds of some people today that cybersecurity patching can't be done without reapproval of the device, and that there's an implication that the FDA is the resistance to why patching can happen. But you'd have to have your head pretty deep in the ground right now if you still held that opinion. Certainly post omnibus bill, which actually made it more of a regulatory authority.
Right. And I have to imagine that any medical device manufacturer around 2008 would have been an interesting time if you had any responsibilities or accountability for security, whether it be IT security for data or whether it be OT, operational technology security, which I think probably very few people would have even heard that term for the design of medical devices. So for somebody designing, say, security defenses, what was that like 15 years ago? Somebody, and you don't have to speak about yourself, many people at the companies.
Well, I think, I think it kind of varies based on how much you believe this was really true. So, going back, prior to that time, I came into the medical device world, as you said, from Honeywell, where I was deeply steeped in safety systems. I worked a lot in commercial aviation, where safety is an incredibly high priority. And so my perspective was safety based. And when I left and went to, at that time, Guidant, I first started working on pacemakers and defibrillators because I had to learn the domain. I obviously had not learned nothing about that in my career at Honeywell. And but about 9 months after I was there, they started building a remote patient management system in response to, at that time, Medtronic had come out with theirs and was starting to see some market shifts. So this was one of these. We got to have one of these too. And so I was recruited because I knew system engineering. I had learned the system engineering skills in working in the aviation world. Boeing is the premier system engineering company. And so we built out a team, and it was at a time when our core market was expanding, if I remember, about 18% year on year, just the core market. And when you have close to $1 billion business growing at 18% year on year, headcount isn't a problem. And so, as opposed to nowadays where people can struggle often to justify additional headcount. And we had a very forward-looking program manager that understood that cybersecurity was going to be an issue for this system and hired in a cybersecurity team. And I ended up becoming lead system engineer on that. And obviously, as a system engineering group, you're intimately working with the usability people, the safety reliability people, and the security team. And we just had a group of people that were appropriately paranoid, had come from various industries where bad guys were an issue. And so we ended up building secure protocols into the link between the implant and the programmer and the implant and the home device. And obviously having a server system with what ultimately is close to 1 million patients on it, HIPAA and all of the security and privacy issues that were dealt with in holding PHI were of paramount interest. So we had actually designed a reasonably secure system that we were pretty confident on. And this was in the period of 2003. We fielded that system in 2006. Mm-hmm. And so we had gotten pushback from various organizations. We just had management that kept the focus on it. And when your paper came out in 2008, I remember a marketing person coming and telling me, he says, "I thought you guys were kind of crazy for doing what you were doing, but thank you." And so it was kind of I came from this culture of, we had done a pretty good job, and seeing that others, I started learning through that we were somewhat unusual in what we had done. And then certainly once we were bought by Boston Scientific, it was a skill that was rooted in the cardiac group, which we had to try to propagate to other businesses that were more in the area of having not thought about it yet. So it was kind of an internal culture clash as we saw justification for what we were doing from the research that you did and the other researchers, but still had the internal struggles to try to convince others that this was a real issue when the regulators weren't demanding it. There's a lot of, if the regulators don't say so, we don't spend money on it. So,
right.
So I saw that struggle that I'm sure other companies were going through it that well, as we were acquired by a larger company and started interacting with the other groups.
So of course now it's not just recommended; it's required by law with some very specific requirements, expectations for things like SBOM. FDA talks about threat modeling. There's quite a lot of detail in there beyond just pen testing. Sort of looking back, there are people participating on this call who are at manufacturers, who are at HDOs, who are in academic centers. Imagine a manufacturer who's just sort of getting wind of, oh, it's actually required, and they're starting to hire. People come from different backgrounds into the medical device cybersecurity field. Nobody is an expert. It's such an interdisciplinary topic. Do you have any advice to the modern day manufacturers, maybe a chief product security officer or somebody who's just starting to roll out their program? What questions should they be asking their candidates, or what should be on their mind when they're thinking, who are the right leaders to put in place to begin or to strengthen a product security program for medical devices?
Interesting question. Yeah, I think clearly we're all dealing with a shortage of available candidates to do that. So, as an aside, I've just started a class at the University of Minnesota on medical device cybersecurity, which is largely dominated by biomedical engineering students and things taking it. So certainly we need to look at the education pipeline as you being a professor to help create more people that think about what it would consider cyber physical system security. It's a somewhat unique perspective in that, and it's not limited to the healthcare space. I mean, all cyber physical systems where you're touching the physical world, from Colonial Pipeline, as we saw, those types of things have a interplay between safety and security, and understanding the impacts to safety and not tilting too far to the safety side, too far to the cybersecurity side. And I always tend to preach that usability is all in there, particularly with things like clinical workflow. At my class last night, Axel Worth was a guest speaker, and he had a chart showing that after a cyber incident, how outcomes became poorer at hospitals, largely attributed to sometimes they put security controls in that interfered with clinical workflow that actually could slow care of the patient. And finding that balance is a challenge. So if I was looking at candidates coming in, I would look for people who have a systems view of things, that really understand, it's out of the system engineering and system thinking in general, is the ability to weigh between disciplines and try to make those kinds of trade-offs. Obviously a large candidate pool comes from IT security, people who've been trained in enterprise security systems. Those people tend to have training in confidentiality, data protection. How do I protect my data? So in the CIA triad, they tend to focus and have lots of experience on the confidentiality side. As we've seen in these attacks that have led to potential patient harm, availability is probably as key as anything. It's the MRI being shut down at the German hospital was a example of a critical diagnostic equipment becoming unavailable, and the emergency department depends on the availability of that equipment to treat critically ill patients when they arrive at the hospital. So, understanding how to maintain the availability of that equipment is critical. And obviously, since medical devices are about diagnostics or therapy related to disease, the integrity of the information. If your diagnostic data is corrupted, you make erroneous diagnoses, and that could potentially harm. If your therapy, your infusion pump, your defibrillator settings, your insulin pump, if the settings get changed, the patient can be harmed. So, understanding and getting whether or not they understand those balances of how do you protect integrity, how do you protect availability, is so kind of systems and understanding those type of things. That tells you whether a candidate might already have the skills to start working it. I think the other aspect is to recognize that because these skills are rare, understanding what training programs you put in place, you can identify talented people within your organization that have those intellectual capacities and send them to appropriate training and things to educate them and bring them more into the ability to do, a product security, embedded systems view of things.
Well, I had to ask that question. I knew we'd go deep on that. We should probably have a whole other session for those interested in hiring. But I want to go backwards in time to 2012. The era before what I would consider oversight, regulatory oversight of medical device security. What happened in 2012? In particular, there was a certain GAO report,
Yes.
Government Accountability Office.
Yep.
What happened there?
Well, I think, the GAO, I think because of this constant drumbeat around insulin pumps and cardiac devices, I think that GAO report specifically identified those two classes of devices as requiring greater oversight. But I think somebody in Congress, I think GAO reports are triggered by a congressional request. And I think because of all of this chatter going on, they asked the GAO to look into it. And they published this report recommending that the FDA improve their processes for dealing with cybersecurity in both the pre and post market environments. And so it really kicked off a expected activity within the regulatory group to specifically focus, try to help solve this problem, because obviously it wasn't going away. And so I think that triggered, and I believe there was two subsequent reports, I think from the FDA, one on pre-market, one post-market, kind of responding to the report. And so obviously there was then activity going on in the background, because if we want to jump forward to the next June, where I think the final trigger event that started exploding, it was in June of 2013. Billy Rios and Terry McCorkle, I think it is, had gone off and analyzed the binaries of bunches of device software, I think, that they had found on the internet from manufacturer sites for being able to download, and did, I think, very standard grep for alphanumerics and various things in there, and found embedded hard code passwords in the software. So if they can find it easy, anyone else can. So the administrative username passwords were embedded in the code and easy to extract. They stopped when they hit 300 and delivered the data to the FDA. And it was like, okay, this is a really bad practice, and creates an easy vulnerability that if they can do it, an ill-intentioned attacker can too. And so I think simultaneously the FDA, they published the information about the 300 passwords. They did a safety alert around it and published the draft pre-market guidance. So obviously pre-market guidance doesn't appear in a month. So I assume that the draft pre-market was being worked on as a result of the GAO report, but the trigger event to get it out was that was the breaking point where they went live.
Right. And so after this draft pre-market guidance came out, which, if my memory serves me correct, was like 3 to 5 pages or so, what I would consider sort of basic security engineering. But in the medical device world, it was a new thing. So there were no standards yet, but there are standards bodies like AAMI.
Yep.
Maybe you could tell me a little bit about, and I know you and I worked together
yes.
in AAMI.
We were the first co-chairs. So yeah, I think one of the things that AAMI does is, I think they look at the issues that the FDA have in front of them and seek ways to partner and create the standards and the materials for supporting those things. So I think our first formation meeting of the AAMI Device Security Working Group was in May 2013. So just a month before the draft guidance came out, as we got together in, I think it was Newport Beach, if I remember. And I remember our first meeting was a landscape look at where are the white spaces? What's needed to try to help deal with this problem? And we ultimately settled on the pre-market security risk assessment, and how do you teach 14971 safety engineers to do security risk assessment? How do you deal with somebody who comes from an IT security risk side, about what the safety side is? And so it really tried to blend that. But that was a trigger mechanism for AAMI to get involved. The result of that, it was 2016 when we came out with TR 57, which has been a big document. But that's a guidance document. It's a technical report, and so breaking news. I see that both Mike Seeberger and Brian Fitzgerald are on, who are the current co-chairs of that, and SW96, which is the conversion of Tier 57 into a standard, into standard for language. was just approved yesterday, the day before, by ANSI. And so it'll be getting published by Amy here shortly. So that's, the next step in now being able to reference something in the form of a standard. But yeah, it was kind of a pull because of that need, and it was a interesting herding cats exercise to deliver a document out of a set. But it's one example of how industry groups and industry partnerships with FDA and with hospitals across the last decade have really helped accelerate the process of being able to do more secure device design.
Yeah, and I find it, at least I find it interesting that the people are just so important. I remember in the room there were representatives from probably about a dozen different manufacturers and healthcare delivery organizations trying to represent different perspectives on some of the earliest standards making.
Well, and at that first meeting, Joe Weiss, who's still a big name in the industrial control system security space out there, I think came in and kind of highlighted what the ICS world had been doing. And certainly the FDA recognized some of the ICS security documents, and the recent release of 81001-5-1 is really a healthcare translation of one of the 6443 ICS standards. So there's been a certain amount of collaboration between industries as well.
We do have one clarifying question about AAMI. What is it? So just, sorry, we've been going through a few acronyms that not everybody is going to be familiar with. AAMI is AAMI. It stands for the Association for the Advancement of Medical Instrumentation. And I believe they've been delegated by ISO to basically handle standards related to medical devices, among other things. And so they run very formal, what I consider extremely organized events, bringing people together and actually getting things done to write standards. And as Ken said, herd cats.
Well, and AAMI really has, I think, two fundamental arms. One is an education arm, a lot focused on health technology management, the BME, and helping the hospital people dealing with medical devices. And then the other side tends to be the standards and standards arm. And so they're kind of one of they're the American National Standard, whatever. I don't know if I'm using the term right, but in representing to ISO and IEC, when you have a country votes and stuff, AAMI tends to be the organization that represents the U.S. in medical device standards at the international level. So,
right. Well, so AAMI really was one of the earliest organizations to get formally involved with very constructive putting things forward. But there are other groups related to medical device security. HHS, so Health and Human Services in the United States, picked up the charge. This was after the GAO report. What were some of the interesting things that you observed in that space?
Yeah, I think as part of the general concern about cybersecurity in the country has, been the identification of critical infrastructures, and recognizing that they are all critical infrastructure is something that is essential to be maintained from the health of our economy, the ability. So financial services, the banking industry has been dealing with cybersecurity issues for decades. And so the healthcare and public health critical infrastructure sector was allocated to HHS as being the organization to oversee that. There was a report in 2017, again, I think it was congressionally asked of HHS, that did kind of an analysis of the healthcare to identify various weaknesses and imperatives. And so there's really two different sides of the HHS activity. One is the Health Sector Coordinating Council, Cybersecurity Working Group. And that group is strategic in nature. It really has taken that 2017 report and tried to use it as a roadmap to create various working groups to bring government and industry, medical device and healthcare delivery, to create documentation to help fill some of these gaps. So, one of the major ones that touches this medical device space is the Joint Security Plan, which was published in 2018, I believe. And it's kind of a guide for how to build out a quality system, cybersecurity into a quality system, somewhat focused at small manufacturers, trying to provide some guidance that would help a company trying to get into this space. But they've created best practices for hospitals, standard contract language, and it's funded by HHS. It does not require membership fees. There's various structures about how to become officially a member of HSCC and participate on the working groups. So the call I was in just before hopping into getting ready at this meeting was JSB is going through its rev for version 2.0. And so we are working through the rewrites necessary to update that, given that much has changed since 2018. And then the other is a health ISAC. And so pretty much all the critical infrastructures have ISACs, information sharing and analysis centers. And the HISACs are the tactical arm. You join it with fees. They provide tactical feed data. So on a daily basis, if threats are being identified, the information that can feed into your intrusion detection systems at your hospitals or companies can be updated with that feed. They also have created working groups, which sometimes create documentation. The one that spans the medical device world is the Medical Device Security Information Sharing Council, MDSISC. And that is got about 350 members, mixed between the biomed networking people at hospitals and the cybersecurity people at medical device manufacturers. And I was co-chair of that for several years before retiring. And so again, that's one of those good forums where you actually bring the two sides together. You have organizations like AdvaMed, which is device manufacturers. You got the American Hospital Association, which is all hospitals. So there's lots of organizations that serve the individual verticals, but it's these touch points where you can actually bring people together from across those aisles to discuss common problems and share information and build relationships. Because sometimes when you're building a device and you want to reach out to get voice of a customer from a hospital, biomed, who are they? Well, if you participate on these organizations, you build those relationships and you know who to reach out to help you in your design activity.
And related to that relationship building, of course, is the IMDRF, or the International Medical Device Regulators Forum. This is where, although there's a lot, the US-centric regulation, just because the US was sort of the leading edge of these regulatory authorities, IMDRF meets every couple of weeks, and you have representatives from all the FDAs of the world, Asia, Europe, Australia, etc., South America. They're working on a number of really interesting documents to bring more harmonization so that you have more clarity. Maybe you can tell us a little bit more about your perspective on IMDRF and what might a medical device manufacturer, or even a small one, want to know about that?
Yeah, I think it's actually a critically important function, because as an area like cybersecurity has continued to become important across the world, there is a natural tendency within the various regulators to try to go on their own and figure out what they should do about it. And as device manufacturers, most are marketing globally, certainly more than one region. And having some consistency in the expectations around a fast-moving area like cybersecurity is important to be able to meet those disparate expectations from the other different regulators. So Dr. Suzanne Schwartz has, of course, been one of the co-chairs, I think, of the cybersecurity activities within IMDRF. And a lot of what the FDA has been leading has filtered its way into the IMDRF, which helps us that are building out our quality systems to try to meet the FDA expectations, have a reasonable chance that you don't have to do something like completely different to market in Australia or market in Europe. So very useful activity, and I think I'm happy to be aware that such a function exists.
Yeah, right.
Otherwise,
And
it
of
would just
course,
be a Tower of Babel.
right. And of course, trade groups are represented there, as well as the manufacturing and HDO communities. So it's not purely just regulators writing some of these frameworks that will probably become guidance documents in countries all over the world, and already have, right? Dozens of countries have already implemented these. So we've got a lot more ground to cover. We've got about 20 minutes left. There's one other organization I think it might be interesting to talk about, that the MDIC, Medical Device Innovation Consortium. It's not just cybersecurity, but they stepped into cybersecurity. What should people know about this, and how does it relate to FDA?
So well, I mean, FDA is a integral partner with the MDIC at the board level and at the various different functional level. So it usually, the documentation that is published by MDIC has been reviewed by the FDA to find that it's not in conflict. They aren't official FDA documents, obviously, but they are at least consistent with the FDA's view. There is a process of a review cycle that happens with there. So the cybersecurity function in there started probably 2017 under their data technology, digital health and data sub branch. And Jitesh Patil has been kind of the MDIC program manager that's driven it. They've started with a document on, and one thing I should mention is all of the things the MDIC does related to this documentation are freely available on the MDIC site. So you don't have to be an MDIC member to download and use their documents. The first one was on the value of a coordinated vulnerability disclosure. And they actually got a law firm to come in and pro bono do a report and interview various companies with the coordinated disclosure, and wrote a report that basically communicates to companies that their liability and corporate risk is lower by having a CVD program in place. So it really kind of addressed, if a company says, well, why should we do this? And it's going to be expensive.
And could you explain CVD?
Otherwise
people are going to think it's a 420 reference.
Yes. No. Coordinated vulnerability disclosure is the process of having a portal, a mechanism that manufacturers put up to receive input from researchers and people who want to report vulnerabilities, and a very specific process by how you intake them, how you interact with the researcher, how you validate whether the finding is accurate, and whether that triggers the need in the end potentially for a cert advisory, a CVE being formed and communicating and providing a patch. So some manufacturers, well, why do I want, in the early days of antagonism, the idea that you would just freely solicit input from researchers to tell you what your risks might be seemed foreign. But again, in the omnibus bill lately, I believe the mandating of coordinated disclosure is one of the factors in there that now has more teeth in it. So, but it was just interesting at that early time that the lawyers came up with it's actually less risk to have one, where a lot of organizations tend to view that it was only going to give them risk by having a free, easy way to tell you. Mm-hmm. And then the other big activity was threat modeling boot camp. So they've created a threat modeling playbook. They did 2 boot camps. This was initially funded partially by the FDA or funded by the FDA completely. And now I believe they are getting the process of offering the boot camp again. So it's a means to get training on threat modeling. That's one aspect. That is a paid activity if you're going to go through the boot camp. So that was, the playbook is a freely available, useful tool. The next one that they were doing, I believe, is in the Joint Security Plan. There's an annex that has a software maturity model.
I'll just put it up here so that attendees can see it. So the document you referenced was jointly between MITRE and MDIC, the threat modeling playbook.
Yep, and Adam Shostak, who is the author of the threat modeling textbook, was what the primary instructor doing with helping do the boot camps and helping drive that activity. And
Well, so what do you think would be an interesting next charge, in your opinion, for groups like MDIC? You know, now that they've worked on cyber disclosure, threat modeling, benchmarking, and other things, what would be a nice next best area of focus for all parties?
You're asking tough questions. Well, an area that would be interesting, or whether a group like that could weigh in on, is we have a challenge in this industry that we have this many-to-many problem of when you want to communicate from manufacturers to hospitals that a new patch is up or things of that nature. You've got thousands of manufacturers communicating to thousands of hospitals, and how do we make that efficient? Because hospitals scanning companies' websites for notifications of new updates is not efficient from their point of view. And sending out notifications to all the hospitals, frankly, medical device manufacturers probably have hospital contacts, but they might be in procurement or things of that nature. Understanding who at the hospital is the person who should be communicated to for issues related to delivery of patches, understanding, compensating controls of that is a different set of people. And so that whole issue of how do you do that many-to-many communication is an unsolved problem. I'm not certain if that falls as a possible MDIC service activity, whether they would be the right place, but understanding and documenting and communicating what the solutions might be an area that hasn't been solved yet.
Well, let's see. Moving on, because there's a few other topics I want to get to. One thing in the weeds. So we talked about threat modeling. There's been already a lot of talk on pen testing, which is important, but I think we can do some more novelty here. Tell us about SBOM. What is SBOM?
So software bill of materials has become the hot buzz, and so I'll just, as an aside, humorous comment. I wrote a blog for Amy on SBOM several years ago, and I titled the draft "You Dropped an SBOM on Me." And when they published it, the editor had changed it, and I asked him why. He says, "Well, I just didn't understand it." And it's like, turns out he was too young to know the "You Dropped a Bomb on Me" song from the 80s. Just dated how old I was. So anyway, software bill of materials is basically a ingredients list of the third-party software that's in a device. And it is, I really see SBOMs as kind of being, useful at three levels. One is at procurement time for a hospital. One is when they do their annual, where's the highest risk in the hospital? Where do I pay attention? And the third, which everyone tends to think about, is, okay, when there's an outbreak of a particular vulnerability, how do I know which devices are affected by that? I see the flip side, which is if a manufacturer can create an SBOM, there's some hope that they can monitor their own devices for vulnerabilities. Because the classic rule one in security is if you don't know what you have, you can't secure it. And so, asset documentation, knowing what you have, is step one. And so SBOM really is we know what we have in our device. And then when new CVEs come out on various components, you have a quick way to do that. So I actually see FDA's regulatory interest in SBOMs as often being, if you can't tell me at submission time what you have in your device, you don't have a chance of managing it in the post-market world. So a lot of activities is moved to CISA, where the activity, because SBOMs is not unique to healthcare. It's really broadly applicable across many industries. But there has been a healthcare test bed going on since its inception to try to experiment it. I think with some of the areas that are a challenge yet is deliver these in electronic form. Is the tooling available? One of the numbers I remember from a conference many years ago is one of the large healthcare systems talked about having 100,000 plus devices from 2,500 different types from 500 manufacturers. So managing all of those SBOMs as a database, much less if you get a firmware update, which comes with a new SBOM because things have been updated. They don't instantly update every device of that type across the hospital, instantly. So you actually will be tracking multiple versions of software for some of those various different devices. So I think the precondition that if you have it, the manufacturer can vulnerability manage is reason enough for SBOMs to be present. I think that challenges for hospital level management of that flood of data have yet to be solved, but that, again, in the omnibus bill, that's another thing that has now been, they have regulatory authority on to insist on SBOMs. So.
Right. So it's expected. SBOM is just one tool. And from a manufacturer's point of view, right, you'll need to be budgeting for these kinds of activities, not just technology, but also people. What are you hearing from the various OEMs on how to prepare for this kind of budgeting now with these new regulatory authorities in the omnibus bill?
I think that's important for all companies and in their product security functions to be communicating upward to make sure that those responsible for the dollars start recognizing that, particularly with the new regulatory authorities, this is no longer an optional activity. And the reality is that I think tooling is going to be needed. And there are organizations that are producing tooling to try to address that issue, which is, a large company that has, 100 different devices on the market and are expected to manage their vulnerabilities. If you have a SBOM in an Excel spreadsheet and manually check your CVE database, every month, you're behind the power curve. You really want the ability to automate that vulnerability monitoring, and having a good library of SBOMs for a manufacturer's device is a precondition for being able to automate the process of letting you know when a new vulnerability in a component that's in one of your devices has been identified and trigger the appropriate assessment activity. It has to become more of a continuous function. It can't be a quarterly or something that's put off, because the manual process is onerous unless you are a small startup company that has a single device on the market. That's a different picture in terms of what the workload is. But so you're thinking about the tooling and budgeting for the tooling and the resources to do the risk assessment. It's not just the tooling in place, but if the tooling spits out that new vulnerabilities have been found, do you have the resources allocated to evaluate them in a timely manner? And I've long been an advocate. I have a Amy cybersecurity article, I think that was published, was it last year, about the idea of software sustaining engineering. Too much of the response to cybersecurity events tends to go to the R&D team that's developing the next product, which means cybersecurity response is always in tension with the delivery schedules for the next device that you've promised to senior leadership you're going to get approval by X. And if that tension exists, there's always the risk that the cybersecurity response for vulnerabilities is put at second stage. So you really need to think about how you staff to make sure that you are able to respond in a timely manner to new vulnerabilities without having the impact on your R&D activities.
Right, and that can be a real challenge, especially with the things being sort of sporadic, and then when a huge vulnerability comes out like Swintooth that just affects so many different product lines with Bluetooth. We only have about 5 minutes left, so I want to get to some things related to the omnibus bill. And there's some interesting language in the omnibus bill about what's effectively regulated. And so they have some wording about can connect to the internet. I think that's closely related to legacy devices, in my opinion.
Yep.
And of course, the IMDRF has framework documents on legacy devices and when does the responsibility shift from a manufacturer or could ship from a manufacturer to a healthcare delivery organization. But what should we be thinking about? What should manufacturers? What should healthcare delivery? What should different stakeholders be taking away from the omnibus bill as the law goes into effect in literally 3 weeks, I believe?
Yeah, I think it's like May 25th, it's something on that or, but it's somewhere in that range. Soon.
Yeah, of course, FDA has stated publicly that they're studying the law and will likely be making announcements on how they intend to carry out those authorities. But what are some of the takeaway points from this omnibus bill for medical device security?
Yeah, I think, well, obviously, as we already touched about, CVD, SBOMs, the regulatory authority that the FDA has been seeking for mandating those. I think, and you correct me if your understanding is different, I'm not certain that these provisions directly apply to legacy devices as much as to new device approvals. But because that's where the FDA has their teeth, is whether you get through the gate. But yeah, it's certainly the language of can be connected, and I think the other one that's a little bit ambiguous that will wrestle with people is, I think, reasonable assurance or use of security. What does reasonable mean? But of course, language in a bill always tends to leave details to interpretation, because there are too many different variables out there to try to put language to nail it down. But
yeah. Well, I think maybe an interesting case, not to name names, but with regards to legacy devices, there was a legacy device, in my opinion. It was removed from the U.S. market through, I believe, a recall, basically because it was very difficult to update. There was no patching mechanism for the particular security vulnerabilities. And legacy devices that tends to be a classic legacy device problem, right?
So I think your leading question is obviously the requirement for the ability and the mechanisms to patch is also in the omnibus bill. So I think they've seen the problem with legacy and trying to make sure that new devices aren't approved in a way that continues to create new legacy problems. So clearly the ability to patch and having efficient mechanisms to patch is just an essential design requirement for new devices going forward. So I think it's good that the FDA is putting the barrier up to make sure that things don't get through the gate that now become problematic once they're fielded by not being able to patch them. And I think clearly with the number of devices out there and the number of hospitals, the days of shipping a service tech out to plug a USB drive into every device out in the field becomes more problematic. Now, real complicated systems like MRI and CAT scan probably have, the maintenance contract ability to still operate on some kind of model because of the complexity, but there has to be more efficient mechanisms for patch distribution, just because otherwise the finances of delivering a patch become a barrier to producing it. It's because if a manufacturer says, well, it's now going to cost us $5,000 a device to go and send a tech out to deliver it, that's too expensive. And your cost benefit analysis starts leaning toward, well, we'll delay this patch. And you really got to get away from bad distribution mechanisms being the rationale for not producing a patch at a particular point in time.
Well, we have quite a few open questions. We're not going to be able to get through them all in the last couple of minutes. Maybe we need to schedule a time at Archimedes in the fall to talk more deeply. But feel free to go through the questions there, Ken, if there are any that you feel like you might be able to address in a few moments.
There was a mention of the new AAMI standard that just got released approved. That is software 96, SW96 is just been approved. And so AAMI has not published yet, but I assume in the next week or two, we'll start seeing announcement that it's out there. Hope you mentioned some of the standards either emerging again. 8101-5-1 ISO IC is one of the key ones that's focused on medical device. As we talked about, J5797 and now SW96 is present. The 80,001 series has 2-1 and 2-2 and 2-8. I think they're all related specifically to cybersecurity aspects. Can I briefly talk about MDCG and how it compares? No, I cannot briefly talk about that.
And I'm afraid we've come to the end of our hour. I feel like we still need another hour to go through a lot of the devil in the details on these things. So much nuance to share on what you've led and participated in over the last 15 years.
Yeah, I think that the final sum up statement is, man, we've come a long way. And there's a lot more to do, but you look at the state of how collaboration is happening, how focus is happening now compared to a decade ago when GAO was saying we need to look at this issue, and based on all the events, we are living in a much better world. We're not there yet, but.
All right. Well, for participants who want to learn more, I can tell there are a lot of questions. I can tell there are a lot of very specific questions, probably on products you're working on right now. You're always welcome to reach out, and we'll let you know about future forums. I'm k.fu at northeastern.edu, or you can just find me by searching for me on the internet. Also, our next CIRSE speaker will be Matthew Hazlett from the Food and Drug Administration, who led the Focal Point program, which educates the reviewers about cybersecurity within FDA to bring more consistency to that process. And so you'll get to hear some of his thoughts on March 16th as our next speaker. But thank you again, Ken, and thank you for continuing to be dedicated even after retirement.
I've been failing at retirement, but what can I say?
All right. Well, thank you, everybody, for joining this event. We'll see you next month.